just opened it.
Okay, sure.
Oh, we just need to switch. Oh, no, thank you. Thanks, though.
The next section would be an interactive session. So we all please scan the QR code below Professor Sadikson's name, please, and I will take you through the questions.
Okay, so everyone's had some coffee and we're all wide awake, and we'll do another session. This one also very similar, mostly case-based to the last session, but I have some questions for some of these cases for you to answer. So I'll be focusing on some interesting cases, some cases that I think are challenging cases, and I'm particularly I tried to select some cases that emphasize some either technical or interpretive pitfalls in chest imaging in the emergency department. So this patient comes in with shortness of breath and has this chest X-ray. Take a look at it, please. And if you've scanned the QR code, my first question to you is, what is the most likely diagnosis responsible for this chest X-ray finding? Is it pneumonia? Is it mucus plugging? Is it lung cancer? Or is it pulmonary embolus? Here's the image again. So please enter your results. Oh, up there. All right, I picked a good question, or a tough case. So we have some pneumonia. We have the largest one looks like we're split between lung cancer and pulmonary embolus. Good. All right, this is a tough case then. So the key thing I want you to look at here, this is left upper lobe collapse. You can see that the left upper lobe is squashed medially against the spine here. But unlike a simple left upper lobe collapse, we have this contour of the lateral margin. This is the so-called S sign of Golden. And normally a left upper lobe collapse would really be flattened like so. But we have this additional bulge here that even our mammographer, I think, recognized from the old X-ray days, right? So here we have this S sign, and what this represents is the lung cancer. This is the mass that is the cause of this left upper lobe collapse. Mucus plugging I mentioned, which would be a great possibility to cause left upper lobe collapse, but should not give us this contour abnormality. Pneumonia, this is a little bit of an odd appearance for pneumonia. There's kind of retraction of the left upper lobe. This is primarily atelectasis, not space-occupying consolidation. And let's see, the last one was pulmonary embolus. This would be an odd look for pulmonary embolus as well. I think maybe what some of you were thinking about was sort of wedge-shaped consolidation from pulmonary infarct, perhaps. The other thing is PE can cause atelectasis, but not normally lobar collapse like this. But anyways, we have this X-ray. We're suspicious of a lung cancer and left upper lobe collapse. So what do we do next? We put them on the truth machine, which is our CT scanner. And here we go. So coming through the same image, there we see the left upper lobe is collapsed. That's that border that we were seeing in the upper part of the S. And as we come a bit lower, we see this outward bulge here from the lung cancer that is roughly located here. It can be difficult to distinguish the lung cancer from the parenchyma, though perhaps you can see that there is a bit of a difference in the enhancement, with a little more enhancement in the lung and a little less enhancement in this mass here. The other thing you can see is if you look at the left upper lobe bronchus right here, it tapers down to nothing right here where it is obstructed by this mass. So this is a left hilar and mediastinal lung cancer causing left upper lobe collapse. I have here as well the axial image here. Again, you can see the enhancing parenchyma here. And as we come a little bit lower, you can see this difference in enhancement. This is all tumor right here, with again obstruction here of the left upper lobe bronchus. That I also included a lung algorithm reconstruction, where here you can see the obstruction of this left upper lobe bronchus by mass. Unfortunately, you can see we have a number of nodules both in the same lung and there we go, in the other lung right here from metastatic disease. In this case, unfortunately, you can see today's finding, this nodule is very difficult to see on this X-ray 16 months earlier. In credit to the radiologist, this was actually reported as a lung nodule with follow-up recommended. The patient never got their follow-up, so the radiologist in this case was not directly at fault for this, but this is a very concerning situation where even if we communicate the finding and recommend follow-up, this does not always happen. This was the outcome in this case. Let's move on to another X-ray case. This patient has facial swelling, and we see these findings. I don't think I put a question for this one, but take a look at the findings, and I hope that everyone here will see this large lung mass here, but what is causing the facial swelling? Well, we also see this large right suprahilar or paratracheal mass right here that is perfectly positioned to obstruct the SVC and cause facial swelling or potentially arm swelling as a cause of SVC syndrome. So if we look at our CT scan, actually let me start at the back in this patient. There's our lung cancer. Here is our very large mediastinal nodal mass that is centered around the SVC. Here you can see the lower SVC. Here you can see the upper SVC, and it is quite narrowed. It's not completely occluded, but it's quite narrowed through this region here. So this is one of the things we're looking for when we have a patient with a syndrome of potential SVC syndrome, potential SVC obstruction. Here is the PET CT. Not surprisingly, we have a very FDG avid primary lung cancer and metastatic nodal disease causing the SVC obstruction. Okay, this is a different patient with chest pain. Portable chest X-ray, low lung volumes. We often look at the mediastinum and try to decide if we think there's mediastinal widening. This is something we are extremely bad at in X-ray, and particularly in trauma. It is very difficult to really call mediastinal widening because it is so dependent on the technique and on the breath hold that's used. What we should do, though, is use comparison imaging whenever we have it. And here this patient in our PACS system had a scan 7 years earlier, which looks a little bit different. If we look at this upper contour here, it's a little bit fuzzy, it's a little bit elevated here compared to here. Very subtle finding, but in the setting of a patient with chest pain, very concerning potentially for aortic dissection. In this case, the patient's, the team was actually most concerned about pulmonary embolus, but after reading the X-ray, even with this very subtle finding, we encouraged them to do this as a dissection study looking primarily at the aorta, and here's what we found. So we see that we have a lot of atherosclerotic disease, we have some ulcerated plaques up here, and as we come farther, we see this aortic dissection here. We have elevation of this intimo-medial flap, which extends down in a small false lumen here. And continuing lower, we see this crescentic soft tissue attenuation along the wall of the aorta that could represent either a thrombosed false lumen farther down or intramural hematoma without true connection to the lumen anymore. It doesn't matter, they're treated the same way. False lumen, thrombosed false lumen versus intramural hematoma are both treated as dissection. And so this patient has an aortic dissection of the aortic arch and the descending aorta, likely related to this advanced ulcerated atherosclerotic disease. If we look at the coronal images, you can see that this upper border here matches this contour that we're seeing here. This is the border forming part on a frontal X-ray here, and part of this contour abnormality has been distortion from this false lumen that is pushing the aorta upwards. So my main point here is to look very critically at the mediastinum on X-ray, use comparison imaging whenever possible, because without it, it's quite honestly very difficult to distinguish a truly widened mediastinum from an artifactually or apparently widened mediastinum due to low lung volumes or portable technique. Okay, another patient with chest pain here. I don't know if you can see this finding, but let's zoom in on this area here. And we've got this. We have a bit of a funny contour abnormality along the left heart border there. Let me show you the CT images that were, or the coronal images that were done next to correlate with that frontal X-ray. You see here, this is the contour abnormality matching what we see on this frontal X-ray. And if we take a look at this, I'm going to ask you the next question. So if you can take out Zuvio, based on what I've shown you so far, what do you think is the most likely diagnosis? We have mediastinitis, epicardial fat necrosis, pericarditis, or liposarcoma. Let's see, how are we doing here? All right, well, we're doing well. So this is epicardial fat necrosis. I'm impressed because I didn't know about this diagnosis when I was at your stage, so that's fantastic. The follow-up number is liposarcoma, which I think should be the second point on the differential diagnosis. Mediastinitis would be very odd to have this appearance. This is very focal inflammation in the epicardial fat. Pericarditis would also be very rare here because we don't actually see any pericardial thickening, we don't see any pericardial effusion. So if we can go back to my images now, please. So if we now look at this on the axial images, we can see that this is all, actually let me go back to the coronals first. So first of all, where is this located? Well, you can see the pericardium located beneath this structure. Here we see a normal epicardial fat pad, the classic location down at the lower left heart border, that often is somewhat see-through on our X-rays. Sometimes we can see a bit of extra attenuation here. We're seeing something very similar here. We can sort of see through this structure. This is predominantly fat-containing because this is predominantly fat. And here we have an extra bulge of epicardial fat, but we have this increased attenuation in the center of it. So let's move on now to the other planes. If we look back at our axial images, we see this bit right here. But I think the sagittal images are the most helpful here because hopefully I can convince you, well, first of all, here's the pericardium. We have our pericardial fat beneath and our epicardial fat above. And what we can see here is we've got a bit of focal inflammation, but perhaps I can convince you that we have some lower attenuation centrally here. And I'll remind you what I showed from one of the last talks on appendicitis, what epiploic appendigitis or segmental omental infarction looks like. We have a central globule of fat with surrounding attenuation. This is the same correlate for that finding in the chest. And we can, particularly in this location, we can see a small amount of our epicardial fat that necroses. The good news is this patient does well, typically in about a week with some pain control with anti-inflammatory medications, and they don't typically need anything else. I don't think anyone would fault you for doing a 3 or 6 month follow-up CT to be 100% certain that this patient does not have liposarcoma. But I think it's also quite reasonable to stop here, make the diagnosis. If the symptoms resolve rapidly, that is all consistent. The other thing that would be very odd would be for a patient with liposarcoma to present with acute chest pain on the basis of this finding. So I think putting all of these things together, if you can make the diagnosis of epicardial fat necrosis, you can avoid a lot of anxiety and some follow-up imaging. Okay, let's move on to the next case. This is a very important one for the residents. So you do a pulmonary embolus CT, and your technologist sends the images to PACS, and maybe they call you on the phone and they say, I don't think you're going to be very happy with this pulmonary embolus CT. What should I do? I still have the patient here on the CT table. So what happened to this PECT bolus? And this is my next question for you. These are the options. 1, the timing is too early. 2, we didn't give enough contrast. C, I should say, transient contrast interruption. And D, our timing was simply too late. I'll go back to the image here so you can make your decision. And if we voted, let's switch to see what people think. Oh, you're still seeing people voting. Good. Vote, vote. Don't be shy. I don't know who's voting what. It's okay. Okay. Half of you thought the timing was too late. Next up was timing too early, followed by transient contrast interruption. Good. Let's go back to my slides. Because this is one that I would love for you to understand thoroughly here. So the right answer here is transient contrast interruption, largely due to Valsalva effect. We know that we're not too early because we have contrast in the aorta. We know that we're not too late because we have contrast in the SVC. So this is very strange, right? Contrast flows from the arm to the SVC, to the right atrium, to the pulmonary, to the right ventricle, to the pulmonary arteries, and then back through the pulmonary veins to the left atrium, to the left ventricle, to the aorta. So we have contrast at the front and at the back, and we have no contrast in the middle. And how can this possibly happen with a serial chain of contrast? The reason this happens is that we have another input, which is the IVC. And the IVC brings unopacified blood in from the legs. And what happens here is typically the patient takes a deep breath in because we've told them to for our CT scan, and that creates negative intrathoracic pressure. At the same time, they bear down, they do a Valsalva effect, which creates positive intra-abdominal pressure. And this pressure gradient drives unopacified contrast from the IVC up into the right atrium. You can see it right here. We have the contrast coming down the SVC, we have unopacified blood from the IVC, and they mix in the right atrium, and they flow out the pulmonary outflow tract with timing that's just perfect to destroy our enhancement in the pulmonary arteries, which is the reason we were doing the scan. So if you see this and you can confidently conclude that we're not too early and we're not too late, that this is a Valsalva effect, it's a very simple solution. Repeat the scan exactly as you did it, but in expiration. If you have the patient breathe out, then you increase the intrathoracic pressure. And if you try it, if you breathe out, it's impossible to do a Valsalva if your diaphragm is down low. So you've eliminated the pressure gradient that caused this phenomenon, and I have never seen this fail to fix a beautiful PECT if this is the cause of the poor enhancement. So this is a very helpful trick to be able to decide what to do next. At our place, we do our PECTs with a small amount of IV contrast, usually 50 ml at 100 kVp. So I have no problem in a patient with normal renal function to give them another 50 ml and to answer the clinical question. The radiation dose I'm also not terribly concerned about because we've brought our radiation dose down so low, partly by using 100 kV imaging, that I would rather give a little bit of extra radiation in these patients and to answer the clinical question. Otherwise, we've done a completely useless exam with no benefit to the patient. So let's move on to the next case. Companion case. The tech comes to you and they say, oh, I don't think you're going to like this. We did not get very good enhancement in the pulmonary artery. So let's analyze this case, please. The questions are exactly the same as I had before. Timing too early, not enough contrast given, transient contrast interruption, or timing too late. And so let's look at the image again and decide what you think is going on here. Please vote. Oh, I'm so happy. Well done. Timing is too late. Perfect. So let's go back to my images and let's talk through it. Okay, so I suspect what most of you were noticing is that we have very good enhancement of the aorta and we have poor enhancement of the pulmonary arteries. The SVC is the crucial thing to look at here. We have very poor enhancement in the SVC. So this is simply a missed contrast bolus. And the reason this happened, if we go back and we look at the monitoring scans, is typically, at least for us, we use bolus tracking. I'm not sure how all of you do it, but we use bolus tracking. And the technologist does a non-contrast image through the pulmonary artery to find it. They put a region of interest here, and they image every second after they've injected the contrast until we reach a certain threshold of enhancement. And for a pulmonary embolus CT, we should be putting that in the pulmonary artery. But look what happened here. We ended up in the aorta. So the patient here took a different breath hold. So they took a breath hold, they imaged the pulmonary artery, they put the region of interest here. The patient unfortunately breathed differently for a monitoring scan, and we missed the bolus. Now, this could be avoided if the technologist is not relying so heavily on our technology, and if they're watching the scan, they would recognize that we've fallen off the pulmonary artery, and you can actually tell with some experience from watching the images when the contrast is flowing where it's supposed to. But in this case, because we ended up with the monitoring scan in the wrong place, the solution here is to repeat exactly the same contrast infusion, but put the region of interest in the right place, and you end up with a beautiful result. The other trick that I actually like very much is if the technologist is having a hard time from their scan identifying exactly where the pulmonary artery is, or perhaps the patient is breathing very rapidly and they're concerned about missing it, is they should just center on this portion of the mediastinum, put the region of interest here, where we know it won't change at all, and simply watch. And they'll see contrast come in the SVC, they'll see next contrast flow to the pulmonary arteries, and only if they wait much longer will they see contrast come around to the aorta. But as soon as they see the first hint of contrast in the pulmonary arteries, if they trigger the scan, you'll get a beautiful result almost all of the time. Okay, let's move on. Another chest pain patient. There's no quiz question here. So we're just looking at this scan, and we see all of this funny material in the pulmonary artery. This is gas. We can see that we have a little bit in the right atrium over here. And if we come up higher, we can see that we have a little bit all the way up in the veins of the upper arm. This is gas that we've injected with our contrast. So this is probably that the line was not flushed very well, and we have gas coming in to our right heart. This is not terribly common to see this much gas. We'll sometimes see small amounts, but the reason I wanted to show you this is just to see what happens when we have gas in there so that you can recognize this if it happens. Because this causes some confusion sometimes for people with this very funny curvilinear appearance of these things. People start to question, how could this possibly be gas? And the answer is that these bubbles of contrast are floating from here up to here during our scan, during our gantry rotation. Our gantry rotation, depending on our scanner, takes half a second, maybe a third of a second, maybe on some of the very high-end scanners, a quarter of a second. But even so, if a bubble of gas is moving during that rotation, it's in a different portion of the anatomy as we're acquiring the images. And it can have a very funny appearance when you then reconstruct those, and will often have this kind of curvilinear appearance because it's a complicated combination of the motion of the bubble and the motion of the gantry. So it's just helpful to recognize this is simply gas. Now in this case, I wouldn't do anything different about this case. We actually got pretty good enhancement in this case, but somebody was concerned, and so they kept the patient around. They were concerned about a possible air embolus causing a problem for this patient. And just to show you what happens, 15 minutes later, this had all completely resorbed or passed distally into some very small subsegmental pulmonary arteries. So generally not a concern. Could conceivably be a concern if you had a right to left shunt and you could get some of these bubbles up into the brain, but uncommon really to cause a problem. Okay, whoops. How am I on time? Okay, that means I'm good. 3 minutes? That's it? Oh, I'm going too slowly. Okay. All right, let's look at this one then. So here we have another pulmonary embolus CT, and this is a quiz question for you. What is this in the left main pulmonary artery? Here it is now on our sagittals. You can see that there's a change in the opacification here. What did I give you as options? Is this contrast mixing artifact? Is this an acute PE? Is this a chronic PE? Or is this pulmonary artery sarcoma? Vote. Quickly, quickly. I don't have much time. Okay, we have, great, contrast mixing artifact as the most common possibility there. Let's switch back to my slides, please. This is indeed contrast mixing artifact. The key to this depends very much on your window level. So I had narrowed this to a rather narrow window here. If we measure Hounsfield units here, we got a very avid enhancement here, 580 Hounsfield units here. In this portion, that's lower attenuation, 350 Hounsfield units. It is impossible to have clot that measures 350 Hounsfield units. Clot is normally maybe 80 Hounsfield units at the top end. And even if you have a little bit of contrast that's somehow infiltrating into small crevices in the clot, you won't get to such high values. I do like to read images on a window like this. I do not like to be so far past the dynamic range that we're only looking at white. But one way to help troubleshoot this is you can switch to a traditional soft tissue window, and if it's real clot, you'll almost always still be able to see it, even on such a bright window setting from our soft tissue value. So contrast mixing artifact is basically just showing, different enhancement because our contrast has flowed into a different rate. I do want to show you the margins of this a little bit. See maybe a little curvilinear thing, maybe reminiscent of the air bubble that was moving. This is contrast that's flowing during our acquisition, so can have a funny configuration at the margins here like this. Acute PE, it's a little bit of a funny morphology. Chronic PE would generally be either retractile or would have narrow webs but would not be filling like this. And pulmonary artery sarcoma I just threw in because I needed a fourth answer to my multiple choice. All right, let me skip this one actually, and I want to go on to this one. So here we have a patient getting a trauma scan. This is an arterial phase scan in the chest, and I ask you to look at these contents within the lumen of the aorta. Here we are on the sagittal images. You see some contents within the aorta. I do not believe I put a quiz question here, but same as the last case. This is mixing artifact. You see that on a standard window it disappears. I can really not see it here on a standard window. What I'm looking at is very slight differences in attenuation from mixing artifact that are being caused in this case by this contour change right here. This is causing some eddy currents to flow through, and you can actually see here, I hope, some swirling of this pattern. As you might see at the edge of a stream, if it goes from narrow to wide, you see some swirling at the margins here. That's the same thing happening here. And I can prove this one to you because as part of our trauma scan, we also do a portal venous phase acquisition of the abdomen. So, whoops. So 40 seconds later, you can see that all of that has completely resolved. This is a virtue of the fact that we're doing a very early arterial phase, and we see some differential enhancement there. Should I stop or should I do another case? How much time? Maybe we should stop. Okay, very good. Oh, come on, one more case. This is a good one. One last case. All right, this is your one image. Please vote. What is this? So you see here we have some crescentic soft tissue attenuation along the wall of the aorta. What is it? Atelectasis, intramural hematoma, pulsation artifact, non-calcified atherosclerotic plaque. Oh, let me show you the image, sorry. I know it's artificial to see only one image, but this is the game. Should I skip the voting? Oh, there's no question? Okay, all right, well then, never mind the question. But this is a trick. This is atelectasis along the wall of the aorta. Here it is here. If you come farther down, you can see that this deviates off of the wall. The reason I show this is that I have had more than one patient transferred to our hospital by helicopter for aortic dissection when all they have is atelectasis. And at least at our place, helicopters only go one way. So now the patient is stuck at our hospital for atelectasis. And so I want you to be able to recognize this. And so first of all, you look at your lung endos and you see that this moves out into the lung parenchyma. That's the best finding. The other findings are you see this low density portion here along the wall. That's the outer margin of the aorta that you're seeing. You will not see that in intramural hematoma, where the hematoma is within the wall of the aorta. And this is also not atherosclerotic plaque because plaque doesn't look like this. You will typically see low attenuation non-calcified plaque or high attenuation calcified plaque or some mixture, but this is very smooth along the wall. So I will stop there. Thank you for playing the game.
Thank you, Professor Sodikson, for your comprehensive lectures. We have a certificate of appreciation for Sodikson. And for our next few sections, I would like to welcome our moderator, Dr. Wu Hongda from Taipei Veteran General Hospital. Dr. Wu.
Okay, I'm Dr. Wu Hongda from MSK section, Taipei Veteran General Hospital. First, I'd like to express my appreciation to Professor Wing Chen to invite me to here and to give me the chance to host these MSK sections. We have distinguished speakers here. The first one is Dr. Xray Craig. Dr. Craig. Dr. Craig is graduate from National University of Singapore in 1988, and he received his training as fellow in Royal College of Radiologists, United Kingdom in 1995, and Academy of Medicine, Singapore in 2003. Dr. Craig is currently the associate professor and the chief of head of diagnosis imaging in National University Hospital, Singapore. Today, Dr. Craig will give us a very important issue.